All right, good morning, everyone. Thank you all for coming. I'm Dan Haddad, I'm one of the PGY2 residents here. And today we'll be talking about antithrombotic therapy in the setting of spine surgery. So here are some objectives for today's talk and an outline of what we'll be discussing today. So we'll go ahead and start off with some patient cases. We'll discuss some background and go into the details of mechanical prophylaxis, chemoprophylaxis, the timing of these interventions, and current global practices and what everyone's kind of doing around the world. So we'll go ahead and start off with some patient cases. We can start from the bottom here. Anyone want to read this case in question? If it makes you feel any better, there's not necessarily a right answer. I mean, just go through the question answers. All right, so we have some answers here: compression stockings and early mobilization, kind of combination. Does anyone have any different thoughts? Kind of agree for the most part. All right, let's get a little bit more complicated. Anyone want to read this one?
DT is a 69-year-old male with several year history of right lower extremity lumbar radiculopathy and back pain undergoing L4-S1 LAMI TLIF PCIF. How would you manage this patient's VTE risk post-op? SCDs, early mobilization, aspirin 325 BID on post-op day 2, Lovenox on post-op day 1, or Lovenox on post-op day 3. Is there only one right answer?
Disclaimer, there are no correct answers. So we'll go ahead and get back to this, but
I'm gonna start with A and B.
Okay, all right. So again, SCDs, early mobilization, not really any takers for chemoprophylaxis. Any differing opinions in the audience? Move on to the next one. Jason, you want to take this one?
YS is a 72-year-old female with past medical history of CAD status post-10, MVR, COPD undergoing revision, posterior lumbar fusion. She takes aspirin 81 milligrams and apixaban at home. Aspirin held 7 days, apixaban 48 hours pre-op. How would you manage this patient's VTE risk post-op?
Yeah, very low pressure. There's not necessarily a right or wrong answer. Just whatever you guys think.
Yeah, again, I would kind of want to start with SCDs and early mobilization for sure.
Okay.
And then resume aspirin and Lovenox accordingly.
Okay. All right, so kind of a combination of A and E. All right. And here's the last case, kind of getting a little bit more complicated.
Is a 50-year-old male, status post MCC with T4 3-column injury with sensory motor deficits, also with right open tibia fracture, rib fracture, pneumothorax, status post chest tube, splenic lac. Patient medically optimized, taken for posterior thoracic fusion, tibia and knee now. How'd you manage the patient's VT risk post-op? So SCDs, aspirin, BID, Lovenox, and drain plus Lovenox. E sounds reasonable, very high risk.
All right, so, while I can't give you guys the correct answers right now, I just hope that it kind of stimulates some thought into how complex these cases can actually get. Let's keep these patients in mind as we kind of explore the risks and benefits of these different types of prophylaxis. And we'll kind of come back to these and kind of see what our opinions are. We have a question in the audience.
Yeah, so I know recently there was a discussion I had with the trauma team that the trauma surgeons here said from their standpoint, they are not on board with doing any sort of holding anticoagulation for these trauma patients. They say that we are supposed to be performing spine surgery while they are anticoagulated, and they disagree with holding any sort of anticoagulation for these patients. So it's a discussion that we are currently having here.
Yeah, no, and exactly. I know this kind of happens every time. And that was kind of, part of the stimulus for this talk. There's so much unknown and, back and forth between, the spine surgeons and the trauma team and, the other teams that have other concerns in mind. So, hopefully by the end of this talk, we'll have some good answers and, or at least good thought processes when we can kind of discuss with our multidisciplinary teams. So going to the background, the risk of VTE in spine surgery is really not well described. It varies pretty considerably. The risk of these complications really need to be weighed against surgical related complications, most notably epidural hematomas, as well as other hematologic complications. There's many patient-specific variables that we need to consider, especially comorbidities and those that require anticoagulation, the surgery that's being undergone, and how well the patient will be able to mobilize postoperatively. There's currently no established consensus regarding perioperative VTE prophylaxis in patients undergoing elective or non-elective spine surgery. In 2009, the North American Spine Society tried to come up with some sort of consensus, but they found insufficient evidence to recommend any routine use of chemoprophylaxis in patients undergoing elective spine surgery. The Congress of Neurologic Surgeons, tried to look at patients that had some sort of thoracolumbar spine trauma. And again, they concluded there was insufficient evidence to provide a specific recommendation regarding the use of a specific VTE prophylaxis regimen. But they were able to pool their data and they recommended that we do something, but they didn't have a great answer as to what. So how much of an issue is this really? Do we really need to care that much about DVT and PEs in spine patients? Well, the incidence of postoperative spinal thromboembolic events really varies widely. Literature quotes from 0.3 to 31%. These are usually gathered from some small heterogeneous studies. And as mentioned previously, there's many patient factors that play into this. So Lee kind of took a look at this and, they looked at the rate of DVT following major elective reconstructive surgery in patients not on anticoagulation. They found their rate to be 1.3%, with only 0.3% that were clinically symptomatic. They screened about 300 patients on post-op day 5 and 7. However, there was an unknown number of pediatric patients that were included in this, and there was no subgroup analysis that only looked at the adult population. And interestingly enough, the postoperative bed rest was implemented for about a week for most of these patients. ODA also looked at this, looking at posterior spinal surgery, and found their rate to be about 15%, with lumbar surgery carrying the highest risk. They screened about 100 patients within 14 days of surgery. None of them had any clinical manifestations. And again, their kind of take-home point was age was a statistically significant risk factor for VTE events. So bottom line, is this important? The answer is probably. I don't really have great numbers to prove it to you. There's really not that many studies that just quantify the risk of DVT and PE. So that means people are probably doing something to address the VTE risk, since there's not much data on patients that don't get anything. So even though there's not really great data and numbers to give us rates of VTE in unprophylaxed patients, or even spine patients in general, we know that post-surgical patients are generally at a higher risk of VTE. We can postulate that spine patients are at increased risk as well. By way of review, we have Virchow's triad here. It gives us understanding of what increases the risk of VTE. We have hypercoagulability due to surgery, venous stasis. These are probably some of the most common factors that are present in postoperative spine patients. There's going to be some sort of vascular damage, just from the surgery itself, that releases coagulation factors like tissue factor into the circulation. So if we can establish and agree that postoperative spine patients are at a higher risk of VTE, why don't we just prophylax everyone like we do for most other surgeries? Is epidural hematoma really that big of a risk? Well, the answer again is probably. Epidural hematomas are pretty infrequent. There's literature quotes estimated incidence of less than 1%. but when it does occur, it can cause devastating neurologic injury. A study by Glotzbecker reported a 0.2% incidence of postoperative epidural hematoma. They pulled data from about 16 studies. Less than half of these studies had patients on some sort of heparin, with the other portion on no chemoprophylaxis. They found no significant difference between the epidural hematoma risk in these two groups. Schroeder looked at retrospectively at 16,000 patients after a cervical spine surgery, and their incidence was less than 0.1%. However, 33% of this 0.1% had persistent neurologic symptoms at about 6 weeks, despite prompt diagnosis and intervention of the hematoma. This is about 16 patients with the epidural hematoma and 5 with persistent symptoms. So, again, not insignificant. And, just kind of for some background as we move along to help us better understand the risk of epidural hematoma and what can contribute to it in the perioperative setting. This study retrospectively looked at about 15,000 patients, and 0.2% of them had what was coded as an epidural hematoma or something similar, based on ICD-9 codes. Interestingly, they found that patients that were well controlled on anticoagulation did not necessarily have an increased risk of epidural hematoma, but we'll get into that later. So again, just to keep some things in mind, some preoperative risks, if they were over the age of 60, had some sort of preoperative NSAIDs, had Rh positive blood, these were statistically found to have some sort of increased risk of epidural hematoma post-op. Intraoperatively, if the patient underwent a surgery on greater than 5 levels, had a hemoglobin of less than 10, blood loss over 1 liter, or INR over 2 within 48 hours post-op, this was again associated with an increased risk. So we find ourselves here between a rock and a hard place. The incidence of DVT in PE after surgery could be 0.3 or it could be 30%. And these can carry significant morbidity and mortality with them. The incidence of epidural hematoma is also probably pretty low, but a significant portion of these patients can have pretty poor outcomes. And these can potentially sometimes be more devastating than a venous thromboembolism that is promptly diagnosed and treated. So since we have a difficult problem, we have to use all the tools in our toolbox. So let's go through some of these options together. So with mechanical prophylaxis, we usually think of SCDs, but let's throw in TED stockings or thromboembolic deterrent stockings and compression stockings. And also we'll think of IVC filters in the mix as well. So how do they work? Postoperatively, there's usually some sort of dilation of the leg veins. The overdistension that can occur has been shown to result in endothelial cracks, and this can serve as a nidus for clot formation. The blood comes into contact with exposed subendothelial collagen, and the coagulation cascade takes off. So if we can compress the veins and decrease their cross-sectional area, we can increase flow velocity, decrease stasis, and decrease the risk. TED stockings and SCDs both work this way and can help overcome some insufficient venous valves and overall reduce venous pooling. That's a whole section of Virchow's triad that we're addressing there. And also just to kind of make a distinction between TED stockings and compression stockings, especially for some of the interns and more junior residents in the audience. TED stockings provide more uniform flow and are more so for patients when they're minimally ambulatory. Compression stockings are more for ambulatory patients. They have graduated compression that helps technically propel the flow upwards from the feet. So graduated compression around the ankle more proximally can also increase blood flow through this concept. Interestingly enough, these devices have also been shown to somewhat stimulate the fibrinolytic system. They can help modulate some hypercoagulability that's seen under these circumstances. And it's actually been theorized that with SCDs alone, you could potentially or theoretically treat a small venous thrombus just through this process. So let's look at some data. Roquito looked at 300 patients and different combination of TED stockings plus or minus SCDs or warfarin. They scanned their patients on postoperative day 5 and 7. Only 1 out of about 300 patients developed DVT. They also found that warfarin group had excessive bleeding. Not great data was available to compare between these groups. Nelson looked at 117 patients, randomized to TED stockings plus or minus SCDs and aspirin. They had no DVTs at 6 days. But again, look at that aspirin dose, 600 milligrams twice a day. We fast forward about 10 years, another study that found that with SCDs alone, in about 140 patients undergoing posterior decompression infusion, the DVT rate was about 2.8 and PE rate was 0.7 in patients that were scanned on postoperative day 2. 4 patients eventually required an IVC filter. Another 12 years down the line, Mosenthal did a systematic review comparing mechanical prophylaxis and chemoprophylaxis. And although the overall incidence of DVT and PE in chemoprophylaxis was less, it was not statistically significant. Incidence was less than 1%, of VTE, but 6% of the PEs that did occur were fatal. Their epidural hematoma rate was only 0.3%. So if we take this study in a vacuum, the results are actually pretty startling. The epidural hematoma risk is slightly higher than quoted by other literature, but still remains pretty low at 0.3%. But we had more fatal PEs than epidural hematoma. And speaking of IVC filters, McClendon retrospectively looked at prophylactic IVC filters in about 200 patients that were high risk for DVT and PE. And these were patients undergoing complex procedures. So specifically, patients with a history of VTE, some sort of malignancy, hypercoagulable state like factor V Leiden, or prolonged immobilization were considered high risk. High risk procedures were those greater than 5 levels, combined approaches, and anesthesia time over 8 hours. They still had a high rate of DVT and PE, about 18% DVT rate, 4% PE rate, and even 1 paradoxical embolus. But the IVC filter did statistically reduce PE development. And again, this is not much of a surprise. IVC filters are made, just to do this one thing. And for some patients, I think this is a great option. Current vascular literature is kind of straying away from using IVC filters as liberally as they may have in the past. But this should be in our back pockets for certain patients, and we can definitely use a multidisciplinary approach in this case. So what do we do with mechanical thromboprophylaxis? I think the answer is easy, use it for everyone. Whether or not this is sufficient on its own is really the question that we have to answer. The answer is probably not, except for a subgroup of patients. I think if patients are overall low risk preoperatively, they're undergoing elective small cases and can mobilize pretty well and early, TED stockings and SCDs alone are not a bad option. We can benefit from the enhanced venous flow, decreased risk release of endothelial clotting factors, and potentially take advantage of the fibrinolytic properties of SCDs. And also, let's not forget that IVC filters might be a good option for certain patients. So I can see everyone here is on the edge of their seat. This is what everyone's been waiting for. What do we do with chemoprophylaxis? So before we get into it, let's just go over some basic science and some board review materials. So to simply put it, there are generally 2 mechanisms of vascular occlusive events. In the venous system, we think of Virchow's triad. We have hypercoagulability on one end, where we think of trauma, surgery, inflammation that induces a hypercoagulable state. We have venous stasis, usually due to immobility in some of these patients, and endothelial damage, which causes turbulent flow and stimulates a coagulation cascade. We think of venous thromboembolic events. So this includes DVT and PE. In the arterial system, we generally start off with some alteration in the vessel wall, usually a rupture of a plaque that initiates clotting. Stasis is not much of an issue because it's a high pressure system. So here we usually think of MIs or strokes. The mechanisms of clotting are different, and venous clots usually are fibrin rich, arterial clots are usually platelet rich. So let's keep this in mind as we kind of discuss our chemical targets. So looking at the coagulation cascade, there's several areas we can target with drugs. I apologize if this triggers anyone's PTSD here. I'll keep it simple. So the cascade usually starts with tissue factor and proceeds as shown here in the diagram. Ultimately, results in the conversion of fibrinogen to fibrin, which is an essential component of a functional clot. So we have heparin and warfarin. These both work very differently. Heparin works in the blood, directly activates anti-clotting factors, specifically antithrombin. This inactivates the factors that are in the rectangles in this diagram. Warfarin acts in the liver, inhibits synthesis of factors that are in the circles, as well as protein C and S, which usually exert anti-clotting effects. The new oral anticoagulants work directly on factor 10A. Here we have drug targets for antiplatelet drugs. So as you can see, it's a different system. While there is some overlap, there's really not that much overlap with the coagulation cascade. Aspirin inhibits thromboxane A2 by irreversibly acetylating COX-1 on the platelets. And this basically just attenuates the platelet activation and recruitment to the site of vascular injury. Plavix blocks P2Y12, which is an ADP receptor that's on the platelet surface. And there's some other newer targets that also act on this pathway at a different stage. There's also some other medications on this diagram that we won't review today. We don't really commonly see them. And if we do, it's probably time to call cardiology. So, as we can see, we have two very different pathways and mechanisms of clotting, which again, it's very important in choosing the agent for chemoprophylaxis. Are we more so worried about clots in the venous system or arterial system? I know this line can kind of get blurred sometimes, but it's important to consider. So let's look at some of these most commonly used drugs. And again, this is more so probably a review for the residents here. So let's focus on a few factors that are important as we make our choices moving forward. Let's look at duration of action, dose adjustments, and reversal of the agents. Most of the drugs we commonly use will no longer be in effect within about 24 hours or so. If we think about it from a pharmacokinetic standpoint, it takes about 3.5 half-lives to reach a drug steady state. So you can estimate that much time before the drug is completely eliminated, but it's a little bit more complex than that, which we won't get into today. That doesn't always correlate with drug effect. And that can be very variable depending on the drug properties and how it works. The heparins will start to have diminished effects within hours. The novel and oral anticoagulants can take about 1 to 2 days. Warfarin is really just a wild card, and aspirin is not reversible again and can work for up to 10 days, but will have diminishing effects of about 10% or so each day. A lot of these drugs are renally dosed. And again, this is really important for interns and our juniors on call, except sub-Q heparin, although there are special circumstances that exist. So if you want something reversible, you should probably go with the heparins, as there is a reversal agent that's readily available and not too expensive. The novel anticoagulants do have special agents, but they are remarkably expensive and not readily available. You can give Kcentra, which is basically a prothrombin complex, but it doesn't really work too great. Also, just something to keep in mind with warfarin specifically, this medication must be bridged with a low molecular weight heparin until it reaches therapeutic state. As we mentioned before, warfarin does downregulate protein C and S, which are both anticoagulants. So if we inhibit an anticoagulant, we are procoagulant. So if we're already in a hypercoagulable state after surgery, we absolutely need to bridge it until the warfarin is therapeutic. So let's go ahead and dive deeper into these drugs and see what the literature actually shows. So starting with unfractionated heparin, which is what we commonly use with sub-Q heparin. This study by Cox looked at mechano and chemoprophylaxis. They started sub-Q heparin either preoperatively or on postoperative day 0 in nearly about 2,000 patients. They gave sub-Q heparin 5,000 units Q8, which is pretty standard. They did dose adjust for weight and age, and their DVT rate was still pretty considerable. They had 1 and 2.7% risk of PE or of DVT and 0.5% of PE. The risk of or incidence of epidural hematoma was also about 0.5%. So the reduction in DVT was statistically significant, but not the difference in rate of postoperative epidural hematoma. So based on this study, sounds great. Let's just give sub-Q heparin to everyone. But let's not jump to conclusions. Data's not over. Moving to low molecular weight heparins like Lovenox, Zhang retrospectively looked at about 1,800 patients. Half of them were on low molecular weight heparin, and half of them were in a control group. They found decreased venous thromboembolic events, but also showed increased epidural hematoma. They had 7 spinal epidural hematomas in the group. 6 of them required surgical intervention. So that's 7 M&Ms that the spine resident has to present. So I guess we shouldn't use heparin. Well, I'm not exactly sure about that. Moving forward, Russell did a study retrospectively looking at cervical and lumbar decompressions. They started low molecular weight heparins within 24 to 36 hours postoperatively, and mechanical prophylaxis as well as mechanical prophylaxis throughout the admission. They had about 367 patients. There was no postoperative hemorrhage, but 4% rate of acute VTE. DiGiorgio prospectively looked at early prophylaxis within 24 hours after spinal cord injury in about 49 patients. 2 of these patients had DVTs, 2 with PEs, and no epidural hematomas. So again, this is kind of contradicting what we just saw in the last study. These 2 studies both started low molecular weight heparin early postoperatively and showed no hemorrhagic complications. Yet there were still patients that had venous thromboembolic events, but no epidural hematomas. So you're probably wondering, where am I going with this? The point is, this is very controversial. The literature is very variable, but I hope these studies do emphasize that the VTE risk is not negligible, and even on anticoagulation, they're still occurring. So what about the newer medications? Newer is always better. Not necessarily. So Zhang did a retrospective review of Xarelto and Eliquis. They both started either right before or after surgery. They had 240 patients in each group. Eliquis was started 8 a.m. the day of surgery, and Xarelto was started 8 hours after surgery. Both of these were taken for 2 weeks. All patients also had compression stockings for 6 weeks and SCDs while they were in-house. They performed Doppler scans on postoperative day 3 and 7. And both groups still had venous thromboembolic events, about 11 symptomatic DVTs and 3 fatalities from PE. Again, this is not insignificant. There was no statistical difference between the 2 drugs. Potential slight advantage for Eliquis with lower bleeding, but again, both of them did work. We know from other literature in other areas, there was a meta-analysis, looked at 6 randomized controlled trials. They compared efficacy and safety of Xarelto and Eliquis with Lovenox for prevention of VTE after total knees. And their results confirmed that they were more effective actually at prevention of VTE after total knee replacement compared with Lovenox. And it didn't really increase the bleeding risk very much. So, great. The study tells us that they both work, but they didn't really comment on the risk of epidural hematoma. We can assume it was 0 since they didn't mention it. We don't really know for sure, but I don't know about you, but I'm still not totally convinced. So what about warfarin? Warfarin works great as an anticoagulant, but there's very limited data in spine surgery. There's lots of bleeding, and you do need to bridge it. So you're also going to use a low molecular weight heparin. It's very complicated dose. There's a lot of factors, and patients have to go for frequent testing. Not really recommended in the postoperative period unless there's some sort of reason that we need to do it, such as a pre-existing comorbidity. Aspirin, again, there's really limited poor quality studies. There's not really studies out there that tell us great things about its safety profile. As we reviewed, it has irreversible antiplatelet effects for the duration of the life of the platelet, which is about 7 to 10 days. Overall has unfavorable agent characteristics, and we do need more literature. There's some literature out there, that looked at the influence of antiplatelet drugs in general on spine surgery. This study by Shin looked at patients on antiplatelets, including aspirin, Plavix, and some less commonly used medications, as well as some that were not available in the US. This was a foreign study. These patients all had drains that were removed on postoperative day 3, and they looked at blood loss per 10 minutes of surgery as an average. And all these patients had a MRI on postoperative day 7. And interestingly, what they did was they looked at the maximal zone of thecal sac compression by hematoma. They compared cross-sectional area to see the extent and magnitude of this compression. There was interestingly no difference in any of these patients for blood loss or the amount of thecal sac compression. It's definitely an interesting study. They even attempted to kind of look and investigate subclinical epidural hematomas. Perhaps it would have been a little bit more compelling if they had a higher number of patients. Only 34 of these patients were on antiplatelets, and 79 were not on any antiplatelets. So, I think it's a great thought, but we need more patients to really make any conclusions from this. So I probably confused all of you guys. What can we agree on so far? I think we can all agree that warfarin is not great, especially in the setting of spine surgery. If we need to use it, I think we have to really be very cognizant and very careful in our administration of it. Aspirin and antiplatelets can be considered, but again, they're probably not great. But again, something that can be considered, but we need more research. Novel oral anticoagulants, we really don't know enough about. They work great as anticoagulants. They're difficult to reverse, which is the problem, although they're pretty convenient to administer. So I think overall, subQ heparin, Lovenox are probably the best options for chemoprophylaxis. They're easy to dose. They have a rapid onset, and their duration of action is not terribly long. And they're easy to reverse if we do need to in an emergency setting. So, this isn't to say we can't start, with an easy to manage heparin or transition to a novel oral anticoagulant later in the perioperative period when we feel that risk of epidural hematoma has diminished enough. But again, that kind of brings us to timing. And, to Matt's point at the beginning of the talk, trauma and all these other teams are constantly telling us, we have to start DVT prophylaxis right away after surgery. So, when are we supposed to start it? And that's really the question that we need to answer. At this institution, we traditionally wait about 72 hours post-op, although recently we've kind of been moving towards 48 hours, especially for higher risk patients. So in 2020, Alvarado tried to take a look at this. It was a retrospective cohort study. They looked at early versus late chemoprophylaxis in trauma patients. They defined early as less than 48 hours post-op and late as greater than 48 hours post-operatively. They had 206 patients overall. 48 patients received early prophylaxis, 160 received late prophylaxis. 13 patients developed venous thromboembolic events, and most of these were within the late group. And the risk of VTE was actually found to be especially high in those over the age of 45 and those with an associated TBI. Overall, there's really not great timing after surgery. This study kind of gives us a sense that we can probably safely administer chemoprophylaxis within a relatively short amount of time after surgery. And the longer we wait, the higher the risk of venous thromboembolic events. So as we've seen in these studies, the epidural hematoma risk remains pretty low, while the venous thromboembolic risk, even on anticoagulation, is not insignificant. And it carries with it a pretty impressive risk of mortality. So what if we can somehow address the risk of epidural hematoma? Can we lower it even more? So we can still give our DVT prophylaxis, but also try to reduce the risk of epidural hematoma. So one thing that we can think about is drains. We have them in a lot of patients, but unfortunately, studies show that while drains are great tools, they don't necessarily prevent all epidural hematomas. So now the question is, what can we do to make it work? People are trying to look for ways to make drains work and help, because intuitively it should make sense. Especially if the blood is anticoagulated, it should drain easily. If we have an avenue for it to go and not accumulate in the epidural space, that sounds great. So, and his partners looked at different drain diameters. They compared patients that underwent posterior lumbar decompression and instrumented fusion. They had a large drain, which was 2.8 millimeters. This correlates to about an 8 or 9 French versus 1.6 millimeters, which is about a 5 French. They had about almost 40 patients in each group, and the drains were removed on postoperative day 3. On postoperative day 7, they again did an MRI, and like in the last study, they measured the remaining hematoma. They looked at the cross-section at a point of maximal compression of the thecal sac and measured this cross-sectional area. And again, they found no difference between the groups. I think one interesting thing to note is usually at this institution, most of our attendings use a 10 French drain, a little bit bigger, which is about 3.33 millimeters. Again, not a huge difference, but since people are studying this, I think it would be interesting to see if that makes any difference. So again, you're probably wondering, well, why doesn't it work? On also tried to look at this and did a bench study with and found that 2 major contributors were delayed vacuum connection during the case and the use of hemostatic agents. So theoretically, again, like I mentioned, if the blood is anticoagulated, it should flow easily through the drain. Unfortunately, if we hook up the drain to the suction or to the bulb before the fascia is closed, it's really not going to hold suction, and it's just not going to work. So the thought process is, while we're closing fascia and closing the wound, this gives an opportunity for clot to start forming. Again, they don't really offer great solutions, but they're pointing out an area that we can try to work on. Additionally, a lot of times we use hemostatic agents like Surgiflow, and this can contribute to clotting. There's already a plethora of tissue factor and other procoagulants, so any other agent's just going to compound the effect even more. I know, all of our attendees here very thoroughly irrigate. They remove as much as possible, but again, the thought process is any small amount that's still there is going to just increase the risk of propagating a clot. So now you're probably thinking, great. You know, when you go back to trauma later today, Matt, you don't have a great answer. What are you going to tell your trauma attendings? Well, let's see. So there's a survey published in 2020 that gathered data from about 300 global spine surgeons. Most of these surgeons were from Europe, mostly younger in their careers, mostly fellowship trained, and mostly residency trained orthopedic surgeons. And from this survey, we really did see pretty wide differences in what everyone's doing. Most commonly employed methods were early mobilization, mechanical prophylaxis, and low molecular weight heparins that was started pretty early on postoperative day 0 or 1. One thing that they did note was that about 70% of surgeons did use some sort of routine anticoagulation risk stratification, mostly based on comorbidities. They didn't really go into exactly what they used. Did they just use clinical gestalt, or did they actually use a validated scoring system? For example, this Padua scoring system is a validated system, and if we look at it, the components make sense. There's a lot of common sense to it. So most of our spine patients are going to have some sort of decreased mobility. Whether it was a trauma patient and they have all these other issues going on, and they're all post-surgical, so that adds another 2 points. A lot of times we do operate on patients over the age of 70, and a lot of our patients here in the United States are obese. So based on this scoring system, anything over 4 is considered high risk for venous thromboembolism. So as you can see, it really doesn't take a lot to get us into that high risk category. So again, from this survey, they looked at what most surgeons were doing in patients not on anticoagulation preoperatively. And we can see that the spread is pretty variable, but again, the most commonly used agents were mobilization, mechanical prophylaxis, and the heparins. There was some scattered warfarin and aspirin, and a few people, used an IVC filter as well. But for the most part, it was those 3 interventions: mechanical prophylaxis, heparins, and early mobilization. They also looked at patients that did have baseline anticoagulation use, and the results aren't really that much different, except a few more patients or a few more surgeons would use warfarin and aspirin. Again, that probably had to do something with their underlying comorbidities and the medications they were on preoperatively. And again, looking at timing, this is again all over the place, but we can see a tendency. There is a tendency to either start it early or to start it late. There's really not much in between. And interestingly, there's a pretty significant number of people that didn't do anything at all. Well, looking at this just a little bit differently, I think this kind of displays it kind of nicely and breaks it down into different risk stratifications based on previous comorbidities. And again, it shows us the same thing. We either started early, we started late, or not at all, which I think was pretty interesting. And again, if we look at all these different comorbidities, the study showed that 70% of surgeons risk stratified, but based on this data, it doesn't really seem like they did. So what do we make of all this information or lack of information? I think early mobilization is always key, and we should always use this along with mechanical prophylaxis. It's not even a bad idea to send patients home with TED and compression stockings. Chemoprophylaxis is really the question that we need to answer, and it's not necessarily dangerous in all patients. We should consider patient-specific factors, choose our agents wisely, and again, looking at the effect of the drug and what we wish to achieve, and the options we have for reversal in an emergency situation are pretty important in choosing medication. So again, just to review, heparins are quicker off, they're easy to reverse, and overall easier to manage. The new oral anticoagulants are probably just as good, if not better, and they're really convenient to take for patients, but have a longer duration of action and are hard to reverse if we really have to. Risk stratification is very helpful. There's various tools out there that can help guide us. But at the end of the day, we really need more research on the safety of these agents, and most importantly, timing, because that's really the question that we need to answer. So going back to these cases, just again to see if anyone's opinions or thoughts have changed. So we'll go ahead and start with the first one. So this is our 40-year-old female that underwent a 1-level cervical fusion, no significant medical comorbidities. I think our answer was really a combination of A and B, compression stockings and early mobilization. Would anyone argue differently or change their answer at this point? Everyone's pretty much on board. All right, I think that's reasonable. You know, this patient's probably going to get up after surgery, be able to walk around and mobilize and kind of get back to their routine pretty quickly. So I think, you know, compression stockings and early mobilization are a good option. This patient, 69-year-old male, you know, several year history of radiculopathy and back pain, undergoing a posterior spinal fusion. I think our answer again was STDs and early mobilization. No one really wanted to give any chemoprophylaxis. Would anyone argue it differently at this point? Seeing a lot of no's in the audience. Again, I don't know if there's a right or wrong answer. I think STDs and early mobilization are great. I think one thing to consider with this patient is, you know, they're 69, they have a several year history of lumbar radiculopathy and back pain. Are they really going to be getting up and mobilizing very well post-operatively? I think that's, again, something we have to consider and see how the patient does. I don't think it's unreasonable to do some sort of heparin while they're, you know, in-house. And if they're able to mobilize really well when they get out, you know, I don't think we need to continue it, but again, I think it's not unreasonable to consider it. Yeah, this was all posterior, not a combined anterior posterior, correct? Yeah, and I mean, that's a great point. You know, like we saw in that one study, if we had combined approaches, that was considered both a high risk for epidural hematoma and high risk for VTE postoperatively. All right, our next patient, 72-year-old female, coronary artery disease, has a stent, has a mitral valve replacement, COPD, undergoing this huge posterior lumbar fusion. That's a revision on aspirin, Eliquis at home, and we held it preoperatively. I think the answer that was given was E, Lovenox and aspirin. Would anyone change their answer here? Okay. Yeah, I think that's totally reasonable. You know, this patient's clearly very high risk. And, you know, was undergoing a huge procedure. Yeah, sorry, I'm not sure if everyone else heard that. Dr. Malberg, you know, said that he would consider an IVC filter in this patient. And, you know, again, I think that's very reasonable. I think this patient's very high risk for a thromboembolic event. And they're also probably at a high risk for an epidural hematoma. I think the comorbidities really complicate this patient since they do have coronary artery disease on a stent. You know, depending on how strongly cardiology feels, they may want us to definitely resume aspirin. The fact that they have a mitral valve replacement, again, we have to discuss with cardiology, but a lot of times they do want to continue some sort of anticoagulation depending on, you know, the type of valve that was used. But I think IVC filter is definitely a great option.
When on these elective cases,
Dan, at any point
do you stop the Eliquis?
Sorry, I think the question was, when do we stop Eliquis preoperatively for elective cases?
For this type of an elective case?
Yeah, so I don't think the literature actually tells us when we should, but based on the duration of action, half-life of the medication, I think, you know, usually 48 hours or 72 hours is probably sufficient to kind of decrease the anticoagulant effect of the medication.
And what if this patient came in with a traumatic event? Would you operate immediately or would you wait?
So I think that's a judgment call. If, you know, if the patient was stable and you could, you know, safely, you know, keep them on spine precautions until the Eliquis kind of ran its course, I think it's not unreasonable to wait a day or two. If, you know, it's more emergent and you really have to take the patient, you know, we do have reversal agents. So we can use Kcentra, which is the prothrombin complex. And there are specific reversal agents that are manufactured specifically for these agents. Like I mentioned, they're remarkably expensive, not readily available. But I think you could definitely operate acutely, but you would have to reverse it. Sorry, there was another question as well that I didn't get to hear.
So Dan, I was wondering in the course of your literature search for this presentation, if you did come over any literature about, obviously we were just talking about when to stop some of these agents before surgery, but about when to restart them afterwards. Because sometimes cardiologists or other specialists will say, oh, defer to spine surgery regarding when to restart. Sometimes they're more adamant about, oh no, it needs to be restarted day 1 or day 0 or whatever else. But I was curious if there was any data or research that you came across that talked about when to restart something like apixaban or aspirin 5X or something like that.
Yeah, no, that's a really great question. And yeah, I did not really find great data on that. But I think we can kind of, I guess, approach it the same way we would with just thinking about it from a VTE prophylaxis perspective. Like in this patient specifically, because they have the coronary artery disease, they have the stent in place, they have a mitral valve replacement. Again, if it's more recent, then I think cardiology usually is pretty adamant on restarting it as soon as possible. If it's more in the remote past, sometimes they're not as concerned. So, I mean, aspirin, although it has irreversible effects on the platelets, it's going to take some time to take its full effect. So I don't think it's unreasonable to start that a day or 2 after surgery, since it's not going to knock out all the platelets right away. In terms of Eliquis, again, that one study that looked at, starting it even as early as 8 a.m. the day of surgery or 8 hours after surgery, they didn't report any complications, postoperative hemorrhage or epidural hematoma. Again, that's just one study. So I don't think it's unreasonable to restart it within a short duration after surgery if it's really medically indicated. But I think that has to be a conversation with cardiology. But to answer your question, no, there's really not great literature.
So you put them on Lovenox and restart the Eliquis, both?
No, I usually just restart the Eliquis, yeah.
No, in this particular case, you said, I thought you said on Eliquis pre-op, you're starting the Lovenox post-op day 1. Are you stopping or continuing or resuming the Eliquis as well?
No, I don't think you have to.
Yeah, for this specific patient, if it was my patient, I probably wouldn't do aspirin and I would restart the apixaban on day 3.
With the Lovenox?
I think the Lovenox is over. Yeah, I don't think you need both.
Yeah, I don't think you need both. I think the advantage of doing Lovenox while they're in-house, especially in the immediate perioperative setting, is if you do end up having one of those catastrophic events that you need to take the patient back to the OR, the duration of action of Lovenox is much shorter than Eliquis, and if you need to reverse it, you can do it pretty easily. So let's say cardiology was adamant on restarting it on postoperative day 0 or 1. You can say, hey, what if we did Lovenox instead? And then in a few days, once you feel a little bit more comfortable, you can switch them over to the Eliquis. And it's a pretty seamless switch.
A lot of these patients are on these anticoagulants for AFib, correct? Pre-op.
Yeah, so AFib and a lot of times with valve replacements.
Right. So what in the literature, what's the risk of them having a thromboembolic event if they're not anticoagulated for the first 72 hours?
I'm not sure. I didn't really come across that in my literature search.
So it's about 17%.
17%.
Right. So you're weighing that risk versus putting someone on a strong anticoagulation, and if they have a laminectomy or something, especially cervical, thoracic, getting hematoma and neurological injury, could be quite devastating. So you're sort of doing the risk-reward benefits. You can talk to the cardiologist and see how significant it is for them to be on it. And again, if they do have a history of PE or something, and it's a bigger procedure, certainly the IVC filter is a good alternative. But I've gotten a lot of pushback the last few years that vascular really doesn't want to put a lot of filters in people for some reason. But that's the risk that you're trying to avoid. So it's about 17%.
Yeah, that's pretty remarkable. Yeah, thank you.
Dan, this is a little different, but did you look at anything about patient positioning? Because now we use the flat top tables. 20 years ago, we used knee to chest. And, with the tables we used, you had a bolster under the pelvis, which would compress the venous return. Your hip was flexed to 90 degrees and your knees were 2 feet lower than your abdomen. And then your knees were flexed to 90 degrees. I mean, I would think that, as far as stasis and a block to venous return would be tremendous. So I think just that the way we position patients on a flat top would lead to much less stasis. Did you look at anything about that?
Yeah, so I didn't find a study that specifically looked at position, but this one study, that looked at prevalence of DVT did find that there was a correlation with surgical region. So there was the highest incidence with lumbar procedures, about like 26%, and then kind of decreased as you went more proximally, 14% for thoracic and about 6% for cervical cases. They didn't really comment on why, but I think that's actually a really good point. It really definitely could be secondary to the actual positioning of the patient as opposed to the region that we're operating on.
Well, the vast majority of large procedures on posteriorly in a prone position, the bolsters on the iliac crest, so they're not having direct compression on their vasculature per se. Their abdomens are free, so there's no compression on their IVC or anything like that. So their knees are flexed about 45 degrees as well. They all have SCDs on, but the big procedures are all done prone. You're not doing too many large anterior procedures.
All right, and again, going to our last case. This is the.
Hey, Dan, like I said.
Yeah, sorry. Go ahead.
Can I make a quick comment?
Yes, absolutely.
I looked into this at one point in time because my father was on the anticoagulations, all different kinds, and I was really picking the brain of every cardiologist I could find, and it had to do with that relative risk that Gino was mentioning. And although I don't remember the papers that I, chapter and verse what I read, what became very clear though was that if it was new onset AFib and not rate controlled, your risk of thrombotic event was pretty high, and it was always based on not just a percentage, but a percentage over time. And so whether it was 17% over the first 3 months or whatever, and again, I don't remember that number. But what I do remember is for those patients that were in chronic AFib and were rate controlled and had probably formed like a mural thrombus within their atria, so they were more tubular than, chamber shaped, the relative risk that was quoted to me at that time was 3% per year. So, I mean, the risk is really, if you're rate controlled and you've been in that for a long time, your risks of having an event like that are really pretty small over a vast period of time. And it made me, start to think that we were over anticoagulating people. But again, I can't tell you where that came from other than a discussion I had with Dr. DeRazio, and he pointed me to a couple of articles, but that was the number that stuck in my head.
Yeah, that's really interesting. Thanks for sharing that. And I mean, that's definitely something we may discover down the line, that we're over anticoagulating everyone.
I have a comment to make too. I think if the trauma service is interested in, revisiting policies for anticoagulation for spine trauma patients, I think they need to not make unilateral decisions. They need to include spine surgeons in that discussion, because I'm not aware of any spine surgeons that are part of any such committee or decision-making group. It's all about, perspective. They don't want to get dinged because the patient had a thromboembolic event on their service. And we know the risk of thromboembolic events are high for spine trauma and spinal cord injury patients, but the risk of fatal PEs are still extremely low. And I think any spine surgeon will tell you, you get one epidural hematoma and it will forever change the way you practice in your career, because these are catastrophic and they almost never recover. And it's a life-changing event for the patient. So I look at it, so, an epidural hematoma, catastrophic neurologic, compromise versus, an asymptomatic or maybe even a clinically symptomatic DVT, but, it's treated without any, without any significant long-term consequences. To me, I err on the side of preventing the epidural hematoma, but, there's no good literature guidance and direction. As you can see here, the literature is all over the place. There's a lot of differing opinions. So it needs to be a consensus reach among, multiple services.
Hey, Matt, I just want to ask, as a non-spine surgeon and watching all these years where the joint replacement guys, went through all these different medications and seems to have landed on aspirin as the final, solution to their issues. But I guess their hematomas aren't catastrophic. Is that why aspirin has not really been looked at in spine surgery? Because of its length of action and its lack of reversibility, or?
While I don't have a definitive answer for you, I mean, that's my personal opinion. Is it's long acting. Even on patients who stop their aspirin 7 days before surgery, those patients, anecdotally, those patients bleed more during surgery than an otherwise similar patient not on aspirin. So I think your point is correct, Charlie.
And to that point, Charlie, there've actually been even studies about comparing aspirin versus some of these other anticoagulant agents. And we have this perception, because aspirin's over the counter, that it has less bleeding events and whatever else. And a lot of those studies have shown that the bleeding event risk is similar compared to the other ones. For whatever reason, joints, like you're right, they have landed on that. But some of the other studies out there, especially for ankle fractures and other things, have shown that, the bleeding event risk is similar. Depending for whether it's aspirin or not.
I have to say that I agree that patients who've been on aspirin, even if they're off 5 days, 7 days, 10 days, and you're doing some reconstructive surgery, they all bleed more than patients who've never been on aspirin. And if you ever see, I agree also with the comment, if you've ever had a patient with an epidural hematoma and neurologic deficit, you never want to see that again.
And we all have, and they almost never recovered. No matter how quickly you reverse their anticoagulant, no matter how quickly you get them to the OR to decompress them, it's usually catastrophic and the recovery is minimal at best.
Question in the audience here.
Is anyone aware or know of like a large retrospective case control to look at like all epidural hematomas that have had at multiple centers or anything, and seeing like the most prevalent risk factors and what they were on? Is that somewhere out there?
I'm not aware of any multi-center studies, but that's what it would take. And the problem with trying to get a handle on anticoagulation and epidural hematomas is that the incidence of PE and the incidence of epidural hematomas is relatively low. And so none of these studies are powered enough to come to a reasonable conclusion. That's why you see all over the board. No increased incidence with anticoagulation, big increased incidence with anticoagulation. It depends who's looking and what you're looking at. And we're still in the Gestalt phase, where it's how the patient feels, individual patients. I've had both epidural hematoma patients, and I've had one patient a number of years ago, back in the days when patients stayed in the hospital. We try to mobilize them as quickly as we can. And so decompression, laminectomy, lumbar, PO post-op day 2, had a massive PE and died. So it's one of these things where sometimes you're not sure if you can win no matter what you do.
Yeah. All right. Thank you, everyone. Special thanks to Dr. Chiappetta and all the spine faculty. Any other questions, comments? appreciate all the feedback that we've had and all the discussion. All right, thank you. We have a question in the audience here. Thank you.